I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
We'll go on now with the next part of the presentation.
I want to put another.
First, Dr. Harold Sackeim on the short-term neuropsychological effects.
Yeah.
I put it up to right there because it's so right there. So that'll be better for us.
The way things are heating up here today, I think maybe we should evaluate the short-term neuropsychological effects of consensus development. I'm going to break up the presentation into three main areas. The first area will be with respect to orientation. What happens immediately following the treatment? How confused are patients? How long does the confusion last? The next area will concern the very acute effects on other aspects of cognition, in particular memory functioning. And then we'll look at what ECT does to cognitive performance within the week following the treatment. The paper that will follow this will concern the more long-term effects of ECT. To begin, standard ECT procedures as a consequence of general anesthesia and muscle relaxation result inevitably in loss of consciousness and loss of spontaneous respiration. These parameters will return very quickly. However, with the return of consciousness, patients will be confused. This period of disorientation can be very variable, from a matter of minutes to a matter of hours. And it appears that treatment members, aspects of the treatment, can strongly moderate or predict the length of the period of disorientation. And some of the treatment parameters that are important that we'll be looking at concern modality, for instance, whether unilateral or bilateral ECT is used, stimulus dosage and or waveform, the amount of electricity and the type of electricity administered to the brain, cumulative treatment number, where in the course of treatment the patient is, and the temporal spacing of the treatments, how closely the treatments are spaced. Can I have the first slide, please? To orient you, we can go back. These are 49 with a high dose of bilateral ECT. Unclear whether the patients were receiving oxygenation or anesthesia at the time. And what we see is that 2 hours following the end of the seizure, less than 40% of patients could correctly identify the day of the week. That is one end of a spectrum in terms of disorientation following treatment. These data here are data from a recent Columbia study using a low-dosage titration measure with brief pulse ECT, an efficient waveform, moderating the amount of dosage to just above seizure threshold in 49 patients. What we see here is amount of time to recovery of functions measured in minutes, and on average, for instance, in the unilateral group, it would take something on the order of 7 minutes for date of birth to be recalled. Notice here, in a group randomly assigned either to right unilateral or bilateral ECT, that generally orientation was more prolonged, significantly more prolonged with bilateral ECT. This measure here, orientation measure B, is a measure of the amount of time it took for these patients when tested in each and every treatment to achieve full orientation. And in the unilateral right group, on average, it was about 10 minutes for full orientation to be achieved. In the bilateral group, on average, 30 minutes for full orientation to be achieved. So there's quite a bit of contrast in the values that one can get in terms of orientation, and some of this seems to be technique related. Today, of 11 studies that have contrasted unilateral right and bilateral ECT, 10 of them have established that orientation is significantly longer with bilateral ECT, so I don't think there's any dispute about that. 5 out of 5 studies that contrasted unilateral left ECT, ECT the left hemisphere compared to ECT the right hemisphere, found that orientation was more prolonged with unilateral left ECT. So disruption of left hemisphere processes seems to be critical to more prolonged disorientation. This slide presents 2 different examples of waveforms. This is a classic sine wave stimulus, and this is a brief pulse stimulus. Since it's felt that it's the leading edge of a stimulus that's critical in seizure elicitation, depolarization of neurons, brief pulses are often far more efficient in their seizure eliciting properties. Seizures can be elicited with 1/3, perhaps 1/4 of the dosage that is required with the sine wave stimulus. Now, there have been some studies that have contrasted low dosage pulse and high dosage sine wave designs. Now, clearly, these are the types of designs that are confounding the dosage administered in electrical terms with the waveform of the stimulus. Nonetheless, they're quite destructive of some of the variations that we can see in ECT. This is data from Valentine et al. 68, and what we see is particularly prolonged disorientation in the group that received bilateral ECT at high dosage with sine wave stimulation. These are data from the Duke trial that we'll be hearing about a little bit later, reported on by Daniel and Krovitz in this year. They're impressed. And instead of times here to achieve orientation, we're having when in sessions, how late in testing of sessions patients achieved on average orientation. And what we see is that in patients who are assigned to brief pulse, achieved orientation earlier than patients who are assigned to sinusoidal sine wave stimulus, and the same for unilateral and bilateral. Another effect is observed in the study. This is orientation at treatment 3. This is orientation at treatment 8. In this study, we see another classic effect, which is that over the course of ECT, the amount of time it takes to achieve orientation gets prolonged. That patients take longer and longer to achieve orientation following a seizure. And this is one example of something that we'll be looking at again in terms of memory, of a cumulative deterioration pattern. This pattern was observed as well by Fraser and Glass in a 78 study, which was with inpatient. That is, patients were on alternate treatments given bilateral or right unilateral ECT. An amount of time to orient was assessed at the first treatment of a given modality and the last treatment. And particularly for bilateral ECT, you can see this sharp increase here, indicating that as treatment progressed, orientation deteriorated. So clearly, a relevant question in this context is what happens when we try to moderate dosage using brief pulse low dosage procedure. And here we see from our study, contrasting the first 2 treatments and last 2 treatments in the bilateral group, the slope is flat. There is no change. Cumulative deterioration pattern was not observed. Here we see it presented more sensitively in terms of pairs of treatment, same data. And in the unilateral group, in fact, we see the opposite, a significant cumulative improvement. At the beginning of the ECT course, these patients took 12 minutes to achieve full orientation. At the end of the course, they were averaging 4 minutes, unilateral right ECT. Until now, there haven't been many attempts to predict the factors that are related to why patients may take somewhat more time than other patients in terms of achieving full orientation. And what we've seen in our data set is that we can predict some of the variance in orientation time, particularly when we look at right unilateral ECT and use a measure that is based on rather rapid recovery. When patients do recover orientation rather rapidly, the length of the seizure seems to be a critical factor. Patients who have longer seizures will take longer to orient. This is something that has been suspected in epileptology for quite a while. Now, when we couple this with the fact that over the course of ECT, it's traditional for seizures to get shorter and shorter, we might be able to understand why in the low dosage right unilateral condition we observe cumulative improvement. Seizures are getting shorter, and the length of the seizure seems to be associated with the amount of time it takes to orient. Now, when orientation is particularly prolonged, and for instance, by the time of the next treatment, the patient still must. These are data from a study reported in 1979 by Summers et al., in which approximately 40% of the patients in this sample presented a condition that they labeled as an organic mantle syndrome that included continued post-ECT confusion and memory loss. It wasn't just restricted to confusion. What they observed was that this syndrome resolved on average in 20 days, which in contrast to the textbooks may be a bit long. But also critically, what they observed is something that other people have reported, that manifestation of this type of syndrome may be particularly likely in patients who are receiving concomitant medications, and possibly in particular lithium, in patients in whom there are pre-existing organic signs, in patients who are advanced or elderly in age, and another issue to consider in patients who are receiving high dosage, in particular sine wave stimulation. Moving on from the issue of orientation to the issue of the cognitive profile seen just after the patient orients. Again, orientation may be recovered in a matter of simply a few minutes, or it may take as much as a few hours in the most typical instances. Once the patient has recovered orientation, we will see a variety of cognitive deficits. These deficits will pertain to attentional processes, sensory processes, response, execution, semantic memory, and in particular, retrograde and anterograde memory. In fact, retrograde and anterograde memory have been the two most studied aspects of ECT. On this slide, we see data that have been presented by Squire et al. In 1975, contrasting patients' memory acutely after the fifth ECT to their memory before ECT for events that occurred in various time periods. And what we see is this classic pattern of a retrograde memory loss that is most marked for events closest in time to the treatment. And we will be coming back to this and see what happens to this type of loss as time from ECT proceeds. With regard to anterograde memory, this is some other data that had been reported by Squire and Slater. We are looking here at patients' performance on this side on a verbal task, on this side on a nonverbal task. And here patients are presented with material they're asked to learn it immediately and then are retested after a 16 to 19 hour delay. The same procedures are repeated after the fifth ECT. It is now well established beyond controversy that bilateral ECT will result in more profound deficits in verbal memory in both anterograde and retrograde formats in the acute period than unilateral right ECT. Here is data from the same group for unilateral right ECT. What we see, in fact, is that there's no change in the patients that have received unilateral right ECT, no change in verbal memory in this context, but a sharp reduction in capacity to retain information of verbal nature in the bilateral group. There is controversy regarding possible differences or lack thereof between unilateral right ECT and bilateral ECT with respect to nonverbal memory processes. In this study, data was obtained suggesting that deficits in nonverbal memory of anterogrades were more pronounced with bilateral ECT than unilateral ECT. Part of the reason there's been controversy as to whether or not bilateral and right unilateral ECT result in differential impairments for nonverbal or right hemisphere types of cognitive processing has to do with the nature of the tasks that have been used to assess that type of cognitive processing, many of which have been easily subject to verbal encoding. Here are data from our study using a retrograde format where patients are exposed to a set of material that they're asked to remember before each treatment, and then after orientation is established following the treatment, tested on that material. What we see is a classic effect that bilateral ECT results in more of a deficit than unilateral right for word recall. The same holds up in a recognition paradigm, that using geometric shape recognition, and we'll see an example of these typists in line a bit, bilateral ECT results in a greater deficit than unilateral right. And here, using a much purer nonverbal task, we have data supporting the findings just seen earlier that bilateral ECT did again result in a more severe deficit than unilateral right ECT. So from these data alone, one would tend to conclude that across the board, bilateral ECT may be more disruptive for memory, including both left and right hemisphere processes. These are examples of what a shape would look like, and these are examples of nonsense shapes. However, in the same patient set, using neutral face recognition, which in brain damage sample has been a type of task that has been extremely sensitive to impairments in right hemisphere processing, what we have observed is in both retrograde and anterograde formats of testing, no difference between unilateral and bilateral ECT. So we are now at a point where we may have to modify suggestions and think that the two modalities may differ in the types of right hemisphere cognitive processes that show relative impairment. Where bilateral ECT may not across the board result in greater impairment for right hemisphere processes in unilateral right ECT, but it may be task dependent. Now, what happens over the course of ECT? This slide presents a theoretic display of what we would expect. This is a patient's baseline cognitive performance coming in, a treatment is given, there's a very acute deficit and a rapid recovery of function as time proceeds from treatment. However, for some types of cognitive performance, additional treatments are administered before there's complete recovery, so the baseline is pushed down. And if we test them at the same types of points in time over the course of treatment, what we should see is a pattern of cumulative deterioration. This pattern of cumulative deterioration is held up in many studies. Here, going back to a retrograde measure from Squire 74, we see that after the fifth ECT, performance is far reduced than after the first ECT, showing cumulative deficit. Here at an anterograde measure, we're seeing the same type of pattern, that as ECT progresses, particularly in the capacity to retain information over delay, there is a cumulative deficit in cognitive performance. In fact, 16 studies have looked at the question of cumulative deficit over the course of ECT. Does the memory deficits associated with ECT progress? And 13 studies have reliably shown this phenomenon. So going back to the low-dosage titration procedure from the Columbia study, we examined this, contrasting the first two treatments patients received to the last two treatments. And even though we see clearly the difference between unilateral and bilateral ECT here, what we also observe is that the slopes are flat. That with moderation of dosage, there was no cumulative deterioration for these two verbal measures. Again, looking at the nonverbal measures, geometric shape and nonsense shape recognition, again, the slopes were flat. And in fact, for nonsense shape recognition in the bilateral group, we got the opposite pattern, cumulative improvement towards the end of treatment. This battery contained 11 tasks, the most extensive battery that had been used in ECT, in which patients were tested at each and every treatment session on all measures in this battery. No pattern of cumulative deterioration was seen over the course of treatment. The memory deficits acutely were as large at the end of the ECT course as they were at the beginning of the course. So there are some suggestions that manipulation of dosage may be of consequence for the cumulative pattern. These are data for Kronholm and Otteson, again suggesting that what we see is maybe in part a function of the types of ECT we administer. These are data using a high-dosage rectified chopped sine wave, a rather traditional form of bilateral ECT administration. Same dosage condition, same type of electrical stimulation of the brain, but a drug is given, an anticonvulsant, that aborted the seizure, and then a third group received a low-dosage, ultra-brief pulse bilateral ECT. This is the first treatment effect where we're just asking, did the groups differ in forgetting scores as assessed across 3 tasks? And indeed, what was observed, that the groups did differ, with the least amount of forgetting is associated with the bilateral low-dosage technique. Moving on to what we might expect a week following the ECT course. A good deal of the attention in the ECT literature concentrates on those areas where we expect to find deficit, because clearly those are the areas of greatest clinical concern, and those are the areas where which require the most intensive investigation. What is sometimes not attended to is the fact that there are many areas of cognitive function, perhaps most areas of cognitive function, that do not show a pattern of deficit even a week following the ECT course. And to illustrate this, these are data from Aloy et al. 82, the smallest group in Indiana. These data happen to be 2 to 3 weeks following ECT compared to pre-ECT in terms of intelligence scores. But the same types of patterns are seen in other studies with more acute types of testing. And what we see is that wherever changes, significant changes occur in terms of intelligence testing, they are always in the direction of improvement in very large samples of patients receiving ECT. We've observed the same effect in our sample of enhanced intelligence IQ scores following 1 week following the ECT course. Likewise, when we look at data reported in England from Weeks et al. 1980, in terms of a rather large cognitive battery, every task here that is underlined are tasks in which a change was observed when patients were tested from pre-ECT to 1 week following the ECT course. And again, all changes here were changes in terms of significant improvement in cognitive functioning. These particularly concern aspects of attention, vigilance, and some aspects of immediate memory. The areas where there are double stars are areas where bilateral and unilateral ECT differ. And in those cases, bilateral ECT showed less of a significant improvement than did the unilateral right ECT group. This is hardly to say that significant deficits will not be observed 1 week following the ECT course. Of course not. There are areas where there are clear-cut deficits. The two that are of most consequence are some aspects of retrograde memory and some aspects of anterograde memory. Looking at some Squire data from 81, this again is a retrograde task where we see again this pattern where the deficits are most severe for events that occur closest in time to the treatment. This is what it's like shortly after the 5th ECT. By the time 1 week has passed, the degree of deficit is lifting, and by 7 months, it is no longer characteristic. So still at 1 week, compared to before ECT, there is an area of deficit in 1 week, but it is significantly improved in 1 week compared to the after the 5th ECT. In the Duke study, where patients have been tested 2 to 3 days post-ECT and compared to their baseline scores. This is a study, again, that is suggesting that even at this further time point out, manipulation of ECT technique may be of consequences. 4 groups are studied here: bilateral and unilateral, both brief pulse and sine wave. And when brief pulse was contrasted with controls on anterior grade measures, hardly any of the differences, in fact none, were significant. Sine wave contrasted to controls in terms of memory measures, large areas of differences along the direction of sine wave, resulting in greater deficits for both anterior grade and retrograde memory performance. Likewise, bilateral ECT seems to be associated in this study with greater memory impairment at this point in time than unilateral right ECT. So manipulations of technique may be of consequence at this point in time as well. One suggestion that has come out of this work is that, particularly at the acute period, an aspect of memory that may be particularly sensitive, and certainly an area that requires considerable investigation, is that of personal retrograde memory. That is, patients' memory for events that have occurred to themselves, not just memory for events that, for facts about the world. And here again we see, when we contrast the unilateral pulse group sine wave unilateral, pulse bilateral, and sine wave bilateral, that the largest area of deficit 2 to 3 days following the treatment is in the sine wave bilateral group, and that when we look at the pulse unilateral, in contrast to controls who did not receive ECT, no differences at all. Now, one of the classic claims in the literature concerning memory and depression and memory and ECT is that depressed patients differ from normal controls in their capacity to take in information about the world. That is, for example, if presented with a list of material and asked to learn it right there and tested right on the spot, depressed patients will be able to perform poorer on those types of tasks than will normal controls. However, if retested 4, 5, 6 hours later, the depressed patient will retain an equal percentage of the information that they took in as will normal, so that there isn't a deficit in the ability to hold on information once it comes in, but there's a deficit in the ability to get information in, to acquire new information. The other claim is that ECT does not impact on the ability to learn information about the world in terms of immediate memory, but does impact on the ability to retain this information over delay. So that the information will get in, be there briefly, but when tested 4, 5, 6 hours later, much of it will be lost following the ECT course. Now, these are data on a subgroup from the Columbia study of patients compared to controls, which support the first part of the claim, which is that prior to treatment, this is all pre-treatment data, patients take in less information on a task of combined words and faces, or when we broke it down to a paired word and a paired face task. They're taking in at immediate testing less information than our controls. That's the white open bars here. But when retested 4 hours later, the amount of loss between patients and controls was equivalent. So there's no deficit in the capacity to hold on to information. These are data from the classic study by Cronholm and Otteson that first led to the claim that ECT was associated with the development of greater forgetting or incapacity to hold on to information over delay. And actually, when we look at these data, what we see is that what has happened over the course of ECT is that 1 week following the ECT course, immediate memory has significantly improved. And the reason that we see greater forgetting, which was here quantified as a difference between immediate and delayed scores, was because patients are actually able to perform better on the immediate task while there's been no change on the delayed task. So we thought because of this type of problem, where actually they're showing an improvement in immediate memory that wasn't the study associated with relief from depression, that is, the patients who showed the greatest relief from depression showed the greatest improvement, we thought it was important to look at it again. And even though we were using, in this context, a low-dosage titration design, what we did obtain was data that were completely in line with the view that there is this differential deficit, that contrasting the patients pre-treatment, and in this case, on average 4 days following the treatment course, what we see is no change in immediate memory scores. If there's any changes towards slight improvement compared to baseline, but a large and dramatic drop in their capacity to hold this information over delay. But we also saw that when we tested within 24 hours of the 7th treatment, there was impact on immediate memory. The more acute the testing, the more likely one is to pick up new or further areas of deficit. But that even though patients received additional treatment, in this study patients averaged 9.4 treatments, the fact that post-treatment testing occurred 4 days after the end of the treatment course, the immediate memory had recovered. Okay? It is this deficit in ability to retain information that may in part account for some of the persistence in terms of an anterograde memory deficit that we observed in the weeks following ECT. To sum up, ECT produces a range of cognitive deficits. The type of deficit is largely a function of the amount of time since last treatment. What we've seen is that there may or may not be cumulative deterioration in terms of the types of deficits. We've seen that the nature of the deficit will change over the course of treatment, and we've seen that treatment parameters may largely impact on the treatment. What we've also seen is that in a host of areas, ECT may actually result in significant improvement in cognitive function.
Thank you.
One shock treatment can equal 150 joules of energy. This is equal to dropping a hammer on someone's head from higher than a 5-story building.
At the FDA hearings, the testimony on the reclassification of electroconvulsive devices cited the literature as whether signed or false, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts maximum of 0.9 amps and 320 some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer I used to hit a nail. But I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but thank you for your point. I'd like to go on to the next person.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never got
All right, out with your gum. Out with your gum.
Okay, this won't hurt. It'll be over in just a moment. What's that?
Conductant.
Oh, dab will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Oil?
Now just bite down on it.
Oh.
That's right. Just bite down. Now bite down on it.
Good. Are you ready? Here we go.